My name is Dr. Ashley Greenwell, and welcome. To introduce myself, I'm a psychologist by training. My background is in understanding how chronic stress and trauma both impact us psychologically, but also the physical body. I'm pretty excited to do this talk for a few reasons. One, many of us know and have heard about the negative effect that trauma processing treatment can have on people when they're not adequately prepared and they don't have the resources to be able to engage in a way that's healing. So I'd love to take some of this time to be able to walk through what are the key components, right? Like if therapists had much more time than realistically many of us do, what would we be reviewing in detail? And at the end of this talk, I'll go through some helpful tools. One kind of idea as you listen through, if you're a therapist, perhaps consider what are the things you might be saying to your client, what would be different? And as a client or someone who's going to be in trauma processing treatment or in therapy, perhaps you're writing down ideas of questions you may ask your therapist. Okay, let's see. Let me go ahead and jump into the slides. I will be posting all of these slides on my website. I can go ahead and share that. I'll share it in the comment section. And then if you're interested in future talks, I often will post them either on my LinkedIn or my Twitter account, and I'll post that info too. All right, so let's jump into it. Okay. In terms of what we're going to do today, I did my introduction. There's no known conflicts of interest. I'll go through a little bit of the research and what that might mean for you personally, but also what it might not mean for you, which I think is important, and then into some practical ideas and time for questions. Okay, all right, so I got to go through this part. I'm obviously not giving any medical advice today to anyone in specifically. I'm not your provider, and of course you'd want to check with a healthcare provider. And that really gets at this idea that it's really hard to speak in absolutes, even though it'd be nice for clarity when we're talking about trauma. Trauma does not happen to a blank slate. And so what that means is the context really matters. What's a great idea for one human is not a great idea for another. And so for almost everything I say today, of course, yes, there are some exceptions, right? So I encourage people to always sort of check in with their gut and instinctual wisdom. So first, just to get through some definitions, when I say trauma processing or trauma-focused treatments, I just want to acknowledge that there are many valid ways of defining that, right? So if you look at the National Center for PTSD, they'll list certain types of treatments that have a certain level of research behind them. If you go to other resources, you'll see different options. And also, this is a cool slide from Dr. Thelma Bryan Davis, really talking about how largely there hasn't been sufficient space and room given to some really important treatments that may be much more helpful and appropriate for certain groups. And then, the only other point I'll make with this is that, what do I mean by trauma? And I'm reluctant to get into a huge discussion about what I mean by trauma, but for the purpose of today, what I'm saying is that the individual has come into contact with something in their environment that has overwhelmed their coping resources and made it so, that typical resilience pattern that, thank goodness, most people are able to do, where you have PTSD symptoms, but then you go back to baseline, is not possible, right? And there's a range of really valid reasons why for some of us at some points in our life, that doesn't happen. Okay, so we'll talk more. Key questions. My goal is to get to all of these. I hope that we will. Really helping you take a look at when is trauma-focused treatment helpful? What do I need in my environment? Red flags. How might we get in our own way? And okay, well, if I know I don't want to do trauma treatment, what else is out there? So we'll touch on each of these today. I want to start with when is trauma treatment likely to be helpful? So theoretically speaking, when we look at the societal cost of untreated trauma, it is profound. You know, for an individual, it's really in the millions of dollars when you think about the impact on their health and their susceptibility to the chronic inflammation and some of the chronic health conditions that can cause, right? And here's some of them listed. So generally speaking, if the PTSD has not remitted within a year, there's some really good arguments to getting access to these evidence-based treatments, right? But let's move and talk a little bit more about some specific groups, right? Or some specific situations in life. Okay, so, and again, the overall, these data that I'm going to share from the studies suggest, yes, it's probably worth it, right? Even in some more stressful life periods, but not always. So this first study looked at homelessness, so people who had unstable housing, right? So facing some major basic stressors. One of the things they found was that the dropout was really high. Not surprisingly, almost half of people dropped out. However, those that were able to complete did get better. So bottom line, yes, it can help potentially for people with unstable housing, but it's going to be tougher to keep people in treatment for, you know, justifiable reasons. Substance use in PTSD. Again, you're seeing a small minority reporting increase in symptoms and also a subgroup reporting increase in suicidal ideation, which means sort of thoughts about suicide. But most are not reporting that. And then here's another study that really looked at, okay, well, let's just compare it to a regular educational group. Like, is it really the contact with trauma and traumatic content that's making them worse? And actually, they were equivalent. So this provides some evidence that perhaps adverse events like a worsening of symptoms or relapse in substance use and so on, maybe they just happen in life. And it may not be confronting the trauma in processing treatment per se that's causing it. Right? Pregnancy was another group. And generally speaking, recommendations are that during pregnancy, it is helpful to treat your PTSD, right? Because there are some negative effects of living with the chronic stress response of PTSD. And here's a study that looked at that. Most completed, there were not many adverse effects. Certainly there had to be more orientation because there was some nervousness in this particular study around, oh gosh, what does it mean with while I'm pregnant that I'm thinking about these things. There was one participant that stopped because she became too suicidal. And, you know, I think this is notable because this really gets at the fact of if you were to talk to most of the participants, word of mouth, they would say this was a great idea, but that is not always the case, right? Complex PTSD. So when someone is demonstrating PTSD from repeated exposure to trauma and may have more dissociative symptoms, initial studies are not showing major differences in terms of adverse events. And that was against a few different types of trauma treatments. Now, just because their symptoms may have gone up, I also want to make the point that doesn't mean that they dropped out, and that doesn't mean that they ultimately didn't get better. So really sticking with clients, even when things do get tougher, there can be a rationale to keep going. Now, I'll show a few more studies on the next slide, but one point I do want to make is if treatments have made it to the randomized controlled trial, official study, our gold standard study, chances are it's a trauma treatment that has been somewhat examined and is promising. I do want to put it out there that if you Google online trauma treatments, you're going to find so many options marketed to you. And the rate of adverse events could in fact be higher if you're not using a sort of reputable, validated treatment. Okay, so here's another look at that. Psychosis, right? It used to be when we were screening for trauma-focused treatment 15 years ago, we'd often worry about psychosis as a rule out. So if someone was having hallucinations or delusions, we'd be concerned about, do we start trauma-focused treatment? But the research is coming out and saying, actually, it may reduce adverse events. This was a study where people with psychosis were less likely to be re-victimized, actually safer than those just on the wait list, right? That said, about 2% did have an increase in symptoms. And so that begs the question for anyone doing this treatment, making sure you have a margin, right, to the extent possible that you can control that. Can you handle it if the symptoms get worse? But they may also get worse while you're waiting for treatment, right? And one of the things that I think is important to look at is, let's say you're in trauma-focused treatment and your symptoms do get worse. What kind of attributions will you make about that, right? Will you say it's the treatment, and that may very well be? Will you say it's something else? So I think that's an important consideration. What will the therapist say? Will the therapist assume it's part of the treatment? And these are important things to be exploring. The number of studies out there, I picked one, shows that there are fewer adverse events in trauma processing treatment than in waitlist. This particular study was with trauma-focused CBT, which is a really well evaluated treatment. Now, I want to bring up a little bit of an exception. So for borderline personality disorder, which is a condition that is marked by a tremendous amount of suffering for the individual and intense difficulty regulating emotions and behavior. While those who did DBT-PE, which is a very specialized targeted treatment for people with BPD, it's basically a combination of prolonged exposure and dialectical behavior therapy. Most people did not have an increase in self-harm or suicidal ideation. So on one hand, that's really promising if someone with BPD can get access to this particular type of treatment. But I also want to point out this graph over here to the right, which basically said, look, while in even this specialized treatment, about 17% made suicide attempts and about 67% self-harmed. So again, I think this is really underscoring the point that some real care and thoughtfulness needs to be used because adverse events could be common in this group. And my own personal risk threshold would be, if someone has BPD, this is the most evidence-based option. I've heard stories and seen negative effects where a client with BPD will maybe get a week or two of resourcing and then try EMDR. And oftentimes that can really send them into more chaos. All right. So, when I say adverse events, what most likely are the things that we're talking about? Frequently, it's just that I don't want to say just, but their PTSD symptoms get worse, right? Substance use can go up, as well as anxiety and depressive symptoms. This other category, what that one includes is things like hospitalization, self-harm, and job loss, other things like that, okay? So again, this is the question you may want to be asking yourself as a client potentially starting this. Do I have a margin? And do I have the skills when things flare up to safely cope? Again, I made this point a little bit earlier, but sometimes we can look at the anticipated pain and think, oh no, I don't want to do this, right? And I say this not only as a trauma therapist, but as someone who's done trauma treatment myself. But I really do want to make this point here that PTSD, if it's become chronic and lasted, it's unlikely to remit on its own. And oftentimes we'll do this exercise where I'll have clients look in the recent rearview mirror and see what their life looks like. And there's very little reason to suspect that it's going to go away, that the future will look different without some kind of intervention. Okay, I love doing thought experiments. Let's do a thought experiment to really kind of get into this. So you can see right here, this is one of those ice baths, right? And depending upon where you are right now, many places are starting to get pretty cold. But let's imagine you decided for whatever reason, maybe it's Wim Hof, maybe, it'll reduce your inflammation. You decided you're going to go outside and you are going to get into an ice bath for 5 minutes, right? Something that part of your brain knows could be good for you. And then it's something perhaps another part of you thinks that sounds really painful and terrible, right? So in this thought experiment, I want you to check in with yourself and just notice the manner in which you would go about it, right? What would your thoughts be doing as you're getting ready? What fears would show up? What questions would you have? What would you feel like you have to know before you do it, right? What reactions to your emotions would you have? Any judgments? Any tendency to talk yourself out of it, to blame someone else? How would you decide when you'd quit? Right? For me, the style that I learned initially that I'm kind of working on is I would probably tense everything and just commit and grit, right? So, I will just endure. And I bring that up because now I have jaw pain over the years. I bring that up because that is not the approach that trauma therapists are hoping for from their clients, generally speaking. That there is a much more sort of, instead of white knuckling it, a gentle way to engage with a sense of perhaps some uncertainty, but also a sense of safety of like, I can control the pace, I can control the intensity, and I'm not alone in this, right? As opposed to feeling forced, right? And so that gets into this idea of cultivating a healthy mindset. Paul Bloom is a researcher at Yale, and he talks about this idea of chosen versus unchosen suffering. Let me tell you, there is a big difference. And I mean, there's a big difference with my clients or someone who were to come to me and say, I have tried my best to bury this in the basement. Here I am, I'm ready to unpack it. As opposed to someone walking in saying, oh, my wife says I have to do this. I don't want to do this. Just make me do it. Just get this over with, right? The way that their body and mind are engaging is very different. And I like to show clients that this isn't just an either or, right? You hear the word acceptance a lot, and I like to think of acceptance as a really fluid concept, meaning like there is a lot of variability, and that gets at this continuum I'm showing you here. So some days you may be feeling aversion, right? Like, I don't want to go to session. I don't want to talk about it. Other days you may be surprised and you may be over in the tolerance of like, all right, let's do it. And then by the end of treatment, sometimes you'll actually find yourself befriending some of it. An example of that might be like my scared inner 9-year-old. If she starts freaking out, I might have this sort of tender stance towards her, right? I might think, it's okay. I know you're trying to look out for me. We got this, right? And there's some warmth in there to that tightness and fear. The other thing is setting your values, intentions, and expectations. It's a process, and this reducing trauma symptoms doesn't solve everything. And we'll talk about this later, but oftentimes there can be emptiness, right? It's like the symptoms are gone, but now what? So much time and effort has been invested in managing PTSD that there can be some grief at the end, right? And then also your intentions for yourself. How high pressure, how perfect do the people have to be in the room? So really just making those known and putting them out there on both sides. Okay. And the other important thing on the chosen and unchosen is that every client can say no. That is the part of informed consent, right? To know that there are other trauma options, there are other interventions that don't involve having to come into contact with the thoughts, memories, emotions, and sensations of the traumatic memory, right? Okay, so what skills and environmental supports help? All right, let's start with biology. So, there is a fair bit of research that basically says benzodiazepines can get in the way. And by that, I mean, those are things that usually like alprazolam, or sometimes maybe people know it as like Klonopin, right? They're these quick acting medications that reduce anxiety, but they can interfere with your ability to benefit from treatment. And so that's worth a discussion. The other hiccup that can happen is when there's major med changes during trauma processing treatment. And what that can do is if someone's getting better, worse, or up and down, it becomes much harder for us to pinpoint what's causing what in the session. Another thing is exercise. There was a really cool study by Powers that showed when clients went and ran after their, I think it was exposure therapy, after the trauma processing therapy, they actually got better much quicker. Their speed to recovery was enhanced. So that's a pretty cool finding. Another thing I'll say is that adequate sleep quality is pretty important. And so by definition, many people with PTSD have problems sleeping at night. However, if your sleep is so disrupted and fragmented that you have trouble concentrating, retaining information, learning, then it's going to be really hard to benefit from trauma-focused treatment in the same way. And so in some cases, it may be worth it to have some of these sleep conditions treated first. The other side of that is if someone has insomnia, the research basically says that you may need a secondary follow-up intervention like CBTI, cognitive behavioral therapy for insomnia. The trauma processing treatment in and of itself may not get rid of those problematic sleep issues. All right, so then psychology, right? Certainly many therapists, they have some kind of window of tolerance graph that they'll show clients, and they're really helping clients try to understand the spectrum of their stress response, right? Like anything from, sometimes it's a 0 to 100 scale that we call a subscale, the subjective units of distress. A 0 meaning I'm completely at peace and calm. A 90 meaning I am shaking uncontrollably and vomiting. A 100 meaning you're probably dissociated and so numb and disconnected. And basically knowing where our body is and what we can do to turn that dial up and down at the different levels is incredibly important, because different skills work for different levels of distress. And if you don't know where you are, which actually, you know, there's, we know that self-awareness decreases in stress. So it's pretty hard unless we've trained to know how upset we are exactly and what we're doing and how we're acting if we haven't learned these skills. So this is important, right? And it can also reduce the risk of a client becoming too flooded in the room and feeling re-traumatized, right? Feeling so out of control. And that's the difference, I think, between someone, when they leave trauma sessions, what I would like a client to be able to say to me is, oh, that was hard, but I did it. I got this. I can do it. Sort of building a sense of confidence and power of like, I can do hard things. We may have overdone it. And obviously you can't always control for this. When someone says, I don't ever want to do that again. I didn't like that, right? And that's why there needs to be a conversation there, right? Okay. And that gets at the idea of relational trust. Like, can that dialogue happen? And do people have the skills between therapist and client to say those things? Increasing awareness of habits and patterns. So I really like this one. For people in particular who have developmental trauma, or it's sort of like always been there, it's hard to figure out what is a personality trait and what is the PTSD. And so sometimes before beginning trauma treatment, I'll have them practice varying aspects of their routine. Like, oh, I always go to these types of places to eat. I always sit in this location, right? Or I don't talk about these things with my friends and family. And we can kind of begin to explore the difference of, well, when you do it, is it that it just feels kind of like, uncomfortable, not like you, overstimulating? Or when you do it, do you feel true fear and unsafe? And that's a cue to us that this might be an area of trauma that's worth working on. All right. And then also do a test run. So when I do intakes with clients, sometimes, not always, they will discuss some of the details of a traumatic event. And in those important moments, I'm usually watching very closely to see when they come into contact with this type of pain, what does their body and mind do, right? Do they give me the police officer robot version, right? Shutting down. Do they show some emotion, but they can move in and out of it and then they re-regulate pretty quickly? Do they feel like swept away by the wave of distress and it becomes more like a cadence, right? These are all kind of cues of what might need to be developed before beginning. And then I like to also talk about this idea around the resilience paradox. There's a book called The End of Trauma that came out this year. And it's by a researcher from Columbia. And he basically makes the point that despite studying resilience a lot, we're not very good at predicting it, right? We're not very good at having a rule book of do these exact things, and then you won't develop PTSD, you'll heal. Now, why is that? Well, it gets at that idea that different things work for different people, right? He gives an example of someone who is assaulted and then copes for the next week by shutting themselves in their apartment, cutting off all social contact, and drinking too much. And then I think watching comedies. So for some people, and for that person actually, it helped numb the pain and get them back in their window. And then they realized this isn't productive, and then they put it aside and picked up different tools to cope. So for this individual, it was actually resilient behavior. However, as you can imagine, you take another person with another background and history, and you prescribe that, and things could go horribly awry, right? It could send them into, huge depression or other types of problems. So the paradox is there is no inherently good or bad skill for coping, but it's important that it fits what the person needs and that the person can track, is this helping or hurting? And then be flexible enough to put it down when it's not. Okay, I like this. So radically open DVT, this comes from, this scale comes from there. That's basically, it's an approach for people who have disorders of excessive self-control, discipline, rigidity, perfectionism. And many of us can relate with some of these, but where you may sometimes feel like you can't show vulnerability. So instead of doing the scale 0 to 100, they talk about these different substrates, right? And I use dogs. I added those in just because dogs are wonderful. So, but it gets at the same point, right? And when you're doing trauma-focused treatment, oftentimes we're going to want people more in the goal-orienting to threatening place, right? Where they're going to either feel like, okay, this is hard, but I got it, we're doing it, I'm okay. And then maybe up a little to like, oh, this is scary, this is hard, feeling a little bit of that fearfulness. What we don't want is people sitting over in that overwhelmed, shut down, dissociated place, right? Because oftentimes that is just re-entrenching that fear relationship. Now, that's not to say never. There are some clients that I work with that have significant problems with dissociation, such that it really interferes with their ability to kind of complete tasks and stay organized and present. And there are times that very intentionally, we will try to get up to that overwhelming place and notice the quiet cues and signals that, uh-oh, it's getting fuzzy, until we can help that person learn to bring it back down more effectively. But one thing I will add when we're talking about what many people will call the window of tolerance, right? Trying to spread that place where you can be kind of embodied in your own skin and aware, is that there are some caveats for certain groups, right? And there's a lot more research still coming out. But if someone is doing practice out of their comfort zone related to sexual trauma, oftentimes the guideline is that you start way lower on their scale, right? So you're not really pushing the more intense, challenging events. You're wanting them to recreate a relationship of feeling safe and relaxed. And if you're going too fast, too difficult, too high on their scale, that can actually be really problematic. So things like sometimes you're practicing a 2 to a 4 out of 10 instead of a 5 to an 8 on that scale of distress and out of your comfort zone. Another group that's being studied when we look at neurodiversity is that for autism, there's some research that says starting slow and slower and lower can be much more helpful. Okay, all right, so what skills and environmental supports matter? All right, so this first part, you don't have to be a master of self-compassion, but if you are a very unforgiving, cruel coach for yourself, this is going to be painful, right? If you're doing something hard and then you leave and beat yourself up, that's a problem. And so oftentimes as therapists, we're working to help people develop a little bit of that at the get-go. Authentic trust with your therapist. I will practice with my clients saying, okay, when it's too much, too hard, and you know it, what are you going to tell me? What's the sign? And I want to make sure that I know what it is and that they can practice it with me. So when they need it, they can do it. This is a DBT skill called dragging out of behavior. And the idea is if they feel uncomfortable doing it in a rehearsed scenario, it's very unlikely that they're going to be able to do it at a new skill at the peak of their distress. So we're actively practicing that. And then I want to bring that up in the other way. Can the therapist be frank with you? Do you feel confident? Hey, my therapist will tell me what's up. If I'm headed in a tough direction, or if she or he thinks or they think something's not going well, will they say it to me, even if it'll hurt my feelings? There's that trust. And then I do have clients sort of alert their social support network of like, look, please, I'm not going to make any major life decisions. These, next, we'll say ballpark 4 to 6 weeks, I might be not myself. Please be there for me. And then in terms of environment, I think to the extent that's possible, being able to clear some space to focus on the trauma-focused treatment. People often feel pretty drained after sessions. So going straight to work is tough, right? And also knowing that like trauma-focused treatment, oftentimes it's going to be, anywhere from 2 to 4 or 5 months. So making sure you have that space in your schedule to be getting regular sessions. The last thing I'll say about that is I think a safe environment's important. If you are challenging your nervous system with this content and then you are going home or to work or other settings that are not safe, it could very well be too much, right? You need to be able to rest after trauma treatment. So that's important to sort of heal. And okay, so I get asked a lot of times, well, which treatment? There's so many treatments out there. And I want to talk about some of the research, but specifically, but just broadly speaking, I really like this satirical article as an example. And what it gets at is there is some complexity to which therapies get designated as evidence-based and which do not, right? And so when we talk about some of this outcome research, there are, like I mentioned, if you go to different websites, some National Center for PTSD, right, will list perhaps EMDR, prolonged exposure, cognitive processing therapy, but may not include internal family systems. Whereas internal family systems on their website, they may say, look, we have the research, we're evidence-based. And so there are different groups who have different levels and thresholds of what makes a study rigorous enough to prove that it works, right? And on one side of the argument, it's really important to have careful procedures and a lack of bias so you actually know it worked. But on the other hand, there are so many hurdles to actually conduct a large-scale, well-controlled study, right? And those hurdles can eliminate some underfunded groups and options from getting access to being able to do the research to show that their treatment works. The other thing I will bring up is that, we'll see these headlines in the news that this treatment is effective or this treatment reduces PTSD. Whenever I see that, what I do is I go and look at the original article and I care about the magnitude, right? It's one thing to have statistical significance, but if, for example, according to the equation, it's statistically significant in terms of helping, I want to know what it means for quality of life. Like if a client has a reduction of 3 points on a 50-point scale, that may not mean anything. Conversely, it might be huge, right? And then the last point I'll make about research is that oftentimes they're looking at averages, right? And so, for example, like you may not be able to predict from a particular study exactly how much it will help. It could be that some people it helped tremendously, and then there was a small subgroup that it didn't help at all. And again, we don't always have the complexity to understand what predicted who it was good for and who it wasn't. Right? But I do have on here sort of a list of thoroughly established treatments that have been well done and well studied. But however, sometimes another approach really speaks to you, or perhaps you have already a relationship with a therapist that says, that's not the treatment I'm trained on, I'm trained on somatic work, right? That, if it speaks to you, may not be a bad thing, but I think it's really important to track progress, right? To be able to, for yourself, detect what is working and what isn't, right? Okay, I like this. So consider how you might get in your own way, or the therapist. So this first one I hear a lot of, and it honestly, so a client, for example, will begin to experience intense emotions or big reactions and think, oh, I'm making too big a deal out of this. I should be over this. There are people who have it way worse. But I hear that across the board, right? There's something almost endemic to having experienced trauma that somehow you feel unworthy or undeserving of getting the help and protecting the space to heal. And so that's something that I'll address with clients really early on. I'll let you read through the other ones on this list. I won't go through them all myself. But giving lots of reinsurance or fragilizing the client. So as therapists, the more training we get and experience, we tend to be more effective at allowing our client to be with painful things, right? The longer I'm in this field, the more convinced I am that rescuing my client from hurting and me being the source of soothing and comforting does not often serve them, right? When I want my clients to feel confident in navigating the world after a trauma, it's not because I'm sitting there as someone to rescue or help them. It's because they have learned I can be with big pain and I can hold it. I've done it before and I can do it again. And that felt confidence is so powerful. And so that means sometimes I am shutting up, right? I'm not telling them the answer. I'm not telling them it's not their fault. I'm not saying let's make this easier unless they ask or there's obvious cues that they can't handle it. So it's one way we can get in the way. Emotional bypassing. So I see this, I'm laughing because I've done this. And my therapist has been wise enough to call me out on it, right? And that looks something like this. I might say, oh my gosh, yeah, it was so terrifying. I didn't trust people for a while. I might even cry a little bit. And then after like a minute of that, I'll say, but look, here's all the good things that came out of it. I'm more confident. I know I'm tough. I learned how to trust my gut. So all in all, it's pretty good. So, a seasoned therapist may be able to take a look at that and say, hey, Ashley, you're moving too quick. You're putting a happy bow on something. And I think you need to be in the pain a little more, right? And that can help us sort of truly process. but it's a judgment call, and that involves that dialogue. Okay, so what are red flags? Now, I bet this list could be much longer, but here are some things to be thinking of, right? 1, the promise of a quick cure. The way that our brain works in terms of additive networks, there is no perfect deletion of trauma. People can get much better. People can reclaim their lives, but quick, easy cures should be suspect. If you're hearing a focus on your therapist's life without a clear rationale, that's a problem, right? And it's worth asking. It's not really about the therapist and their experience. Another thing is if you're sitting in the room worried about the therapist, worrying if they know they're doing a good job, worrying, is the information too distressing for them? That's a problem, right? And so that needs to get brought up. And if your therapist sees you doing that, hopefully they raise it and say, hey, I got this. We're here for you. Being consistently flooded after every session is a problem, often. Feeling judged, right? Feeling like the therapist has some judgments on particularly trauma content is so sensitive. You're not going to feel safe enough. And that might happen initially, but it's worth making sure that you're able to create a relationship where you get out of that. You don't understand why you're doing the intervention. The lack of continuity is another problem. If you're doing trauma-focused treatment, it's not the topic of the week, right? That's really hard to create sustainable growth when there's a new, different issue and you're just sort of doing a buffet. And so it's important that the therapist is helping structure that so that there can be some real growth and movement. Another one is when intensive trauma-focused treatment goes on and on. Therapy is hard work, and if you find it lasting, then often what's happening is it's being diluted. And that's important to sort of take a look at. Okay, so what about when people want to end treatment early? Now this happens for a few different reasons. Sometimes it's about they got better, and that's great. But the why matters, right? Sometimes something happens with a family member that takes priority, and that matters too, right? That's a values consistent choice of I will prioritize this. But if it's because the fear and pain was too much, there could be some implications from that, right? And the reason I have a picture of these two people, one of them is Daniel Kahneman. He's been in the news a lot in the last 5 years or so. And he did a study that basically showed that more important than the quantity of discomfort that you experience is how it ends, because how it ends impacts how you think about it. And I think there can be some connection with how you end treatment. If you have a really rough session and then you call it, that may impact how you relate with the trauma and your ability to tolerate painful things. And so that's why it's so important that this is an ongoing conversation with your therapist. There's almost always ways we can slow it down and make it easier, right? Help titrate your experience if we know it's too much. I also want to bring up the point, I've never had the thought that a client has failed. I'm never disappointed. I'm never upset with them. There are options. Right? Okay. So here's this next question. How to know if this is working, right? And the only other point I'll make about this one is I think many of my clients at some point think about quitting. So that's not unusual in and of itself. It's hard, right? How to know if it's working. It's really important that this gets agreed on in advance, right? With your client. What are the targets? Is it symptom reduction? Are you trying to feel less distress? Is it behavioral flexibility? Oh my gosh, I can do so many more things. And to that point, the reason I have this floor plan here is in EMDR, there's this really nice metaphor that basically says, look, when we experience something traumatic, one kind of very human thing for us to want to do is to take all that stuff and metaphorically throw it in a room and close the door and not go back in there, not wade through it. just move on. Now, the problem is, as we accumulate painful life events, we start to have to close more and more doors, and our space and our freedom and flexibility shrinks, right? And what we know is the more that we shrink and avoid, that stronger that fear network can become. And so one of the things trauma-focused treatment is doing is opening some of those doors and walking back into those rooms. And naturally, that can feel pretty painful, right? And so the exploration you might be doing with your therapist is, am I feeling more pain because I am approaching and confronting more difficult things, right? And is it subsiding over time? Is it worth it? Do I have more freedom and flexibility and a different, more capable way of handling these memories? Or are you just stuck, right? When I see the greater awareness of symptoms, I bring that up because it's not uncommon for clients in the beginning to say, oh my gosh, I had no idea how much trauma was impacting me. It's infused everywhere. And while that can feel a little bit unnerving initially, it's actually incredibly powerful at some of the ending sessions to be able to see the magnitude of growth. Okay, so what to expect after completing trauma-focused treatment, right? Now, this is to the point that there are some really positive things. There can be more hope, gratitude, peace, confidence. But for some people are also surprised that there can be some grief, right? Now that you feel safe enough, that you're not just in survival mode, a lot of sadness, right? At the loss of vitality and loss of years living with PTSD, right? And so that's why sometimes after you finish trauma-focused treatment, some people will then start another approach like acceptance and commitment therapy, right? And know like, now that I've cleared all this room, there's some emptiness and then there's something to be built. Okay, so in terms of next steps, well, next steps of how you can use the information from this talk. One, I want to say, like, if the timing's not right, there are many other important health pillars you can be attending to, right? That reduce stress and inflammation. Many types of providers. The other thing is there's a lot of really good non-trauma focused treatments. Trauma sensitive yoga has more and more research coming out about it. Biofeedback as well. And then if the typical trauma focused treatment was too much, dialectical behavior therapy and DBT-PE can be a really powerful approach to really wade into it with more supports and skills. Now, other next steps may be taking questions from this talk to your therapist. I also want to spend a moment talking about some tools that I use, right? So I love this. This is the Patient Bill of Rights. Oftentimes when I'm very busy as a therapist, which is most of the time, and I can't spend an hour doing all of this, I'll hand them this Bill of Rights and say, okay, please take a look and let me know what you feel like has been addressed and what has not been addressed. Circle the ones, right? And then we can talk about that, right? Helping them know what and why and how this treatment that they're investing in is serving them, right? What it can do for them and what are the risks and benefits. All right. Another thing I'll do is a frequently asked questions. Right? And these are just quicker ways sometimes of getting the information. Another kind of takeaway is here's an example checklist, and you'll have access to these slides, but I'll sort of look at this with some clients and say, okay, what do we need? What do you need for trauma treatment, and where are we on these? Okay, so with that, again, here is some, here's my email address. And then also the slides will be posted on my website under news at the carousel. You'll just click here on this. I'll put the links below actually as well. And you can feel free to download the slides to access them yourself. Finally, you saw a lot of references cited. I have a full page of references where you can look at some of the specific studies. And if you have other suggestions or recommendations for upcoming talks, feel free to send them my way. I will be doing an upcoming ethics talk in 2022, focused on some related ideas for trauma work. I just want to wrap up and say, I know I always struggle here because, and hope that my face conveys what my heart feels about this. Working with clients who have been through trauma is sort of one of the most meaningful things I do. And I know many of us as therapists, it can start to feel like, oh, that's what I do every day, but there is something deeply sacred about it. And if we are able to create these systems and structures that protect our time and space to do this kind of deep work, I think it truly can change individuals' lives. So I honor the work you're doing, whether that's a therapist or as a client in therapy. And again, don't hesitate to reach out to me. I'll go ahead and take questions there. Thanks.